It's like a paramedic.
That's right. It is. Alrighty, guys. So we are going to have a discussion and presentation about physician suicide. And we have Chris Calkins with us today. I was honored to first get introduced to Chris when, unfortunately, we lost a paramedic in 2020 who died by suicide. Chris is an expert on the topic and I think has a phenomenal perspective and story, and I'm excited to hear his talk today. So he is based out of Forest Lake, Minnesota, and he has a number of letters behind his name, as you guys can see there. He's been an EMS provider since the first known extrasolar planet was discovered. Backdraft was released in movie theaters, and Rick Mears won the Indy 500 for the fourth time. Dr. Calkins has practiced EMS in urban, suburban, and rural areas in both the private and public sectors. Spent 15 years in his career in a dual role as a firefighter and was on 3 departments in 2 states. He served as a street provider, a manager, and a college educator. He is a suicidologist, a psychological autopsy investigator, and suicide bereavement peer support facilitator. He's presented on suicide and related phenomena on a national and international basis. Currently works as a medic for Essentia Health EMS and Health Sciences faculty at Century College, and as a private consultant and researcher. So with that, welcome, Chris.
Thank you. That's a bummer. It's like a downer, right? Like he introduces me like physician suicide first thing. So I try to keep a little bit of levity while I talk because this is such a dense, tough, serious topic. So you'll have to laugh at some of my corny bad dad jokes. I'm like the king of them. So it's okay to laugh if I make a joke. Or scratch your head, look at the person next to you and Google what I was talking about, like Rick Mears, for example. I did live in Indianapolis in the shadow of the Speedway for 7 years of my life. That's where I started EMS. I didn't know that it was pronounced rails until I moved to Minnesota because I thought it was Rawls, because I learned medical terminology down there, not up here. So go figure. As was said, I'm a suicidologist. There is such a thing. We do have our own national and international association that I'm heavily involved with. It's taken me all over the world, except for during COVID. It's kind of put a damper on everything. But I'm heavily involved, and I became a suicidologist on March 5th, 2003. And that's the day that my wife, Mary, died by suicide. She was a physical therapist for St. Joe's Hospital. Perhaps you've heard of the place, like where? And Shriners Hospital as well. And then later on in 2008, my brother died by suicide. He was a law enforcement student, and 11 of my colleagues in EMS have died by suicide. So to say this is something personal would be a gross understatement. So I've been touched by this more times than I care to be, and probably will be again. Unfortunately, I know I will be again. So my objective is to hopefully help you understand, help you reflect on some of your own self-care, because physician suicide rates are unacceptably high, and maybe help your family, friends, patients. Notice I put the patients at the bottom, because in this time I want to save you. Who takes care of the people who take care of others is the million-dollar question, right? Unfortunately, that often falls to us to help ourselves and each other. So hopefully I'll put some tools in your toolbox to do that. I want to talk a little bit about some really basic theories on suicide. You will notice that I don't say, except for when I intentionally want to, I don't say commit suicide. That is a big no-no word in the suicidology community. Commit denotes a crime. It denotes a sin. If you can commit a heart attack, I'll let you say you can commit suicide. Or if you can commit breast cancer, then I'll let the other go. Some of you in this room will slip. That's okay. I will still love you. It takes a while to get out of your lexicon. So it's really hard because it's so ingrained. So I just say suicided, died by suicide, killed themselves, that kind of a thing. I also don't use the word successful suicide, because in my mind, there's only one kind of successful suicide attempt, and that's the kind that doesn't happen, if that makes sense. I don't tell other people that because it's just too confusing. Like, wait a minute, there's a successful kind? Yeah, the kind that doesn't happen. And I also don't use completed because then people get in this rut of, oh, I can't even complete. I'm not a finisher. I can't even do that right, and kind of get into this negative self-talk. So I say a lethal or a non-lethal attempt, which is actually pretty clinical and makes a great deal of sense. So a non-lethal attempt. So those are some of my no words. And again, I'll forgive you in advance for saying them because I'm about 99% positive somebody will, and don't feel bad when you do because I get it. It takes me a long time, and who knows what I say about other disease conditions that's kind of not acceptable anymore. So the first theory here is called psychache. People often ask me when they hear about my wife or my brother, my colleagues, they say, isn't suicide the most selfish act anybody can perpetrate? And I say that's a fair question to ask. And before I get into that more, I should tell you also that you have permission to ask me anything about my wife, my brother, my colleagues, myself. I'm okay with that. It has to be okay to talk about it. And people sometimes are worried, like, oh, I don't want to ask him any questions because it'll make him sad or make him think about people he lost. I'm thinking about them every moment of every day. You can't possibly make me think of something I'm already thinking of. So you don't have that kind of power. Just like asking somebody if they're thinking of killing themselves. You don't have that kind of power over somebody. And that's one of the big myths in suicide, right? That asking somebody if they're thinking of killing themselves will make them do it. Unequivocally, the research shows absolutely not. Is there such a thing as suicide contagion? Why, yes, there is, but that's not what I'm talking about here. And if you want to go there, I'm happy to talk about that at the end if we have time, or you can email or whatever. I also always disclose that I have post-traumatic stress, depression, I have anxiety, I take a Zoloft every night, I take trazodone to sleep, and I've been through EMDR therapy, and the world's a better place. And you can be too if you're struggling, and I'm not under the illusion that nobody else is. Yeah? Oh, eye movement desensitization processing therapy. It's one of the few evidence-based therapies for post-traumatic stress, which I'd rather call post-traumatic stress injury because your hippocampus actually shrinks, and with therapy it comes back a little bit because I'd rather have an injury than a disorder, but genie's out of the bottle there. We're trying to shove it. I don't know if we will. Anyway, anything about my mental health is on the table too. I'd like to say I've never suffered repercussions for being this public, but I have. So I don't know if I can tell you should do that, especially so early in a career. And I'm sad to say that. But I have had an agency put my post-traumatic stress on a performance review that didn't have anything, and they couldn't quantify or qualify what I should do to improve myself. That is the sad reality. But whatever. They say what doesn't kill you makes you stronger, right? So everything's on the table. You can ask me anything. I'm an Aquarius. I like long walks on a beach. The first thing here is a theory called the psychache. So what a psychache is an unbearable psychological pain. And we talk about physical pain all the time. In fact, we know that people in severe physical or chronic pain are 2 to 3 times more likely to die by suicide. That makes a certain sort of sense. There's also known attack rates with various kinds of cancers, various kinds of coronary artery disease, and end-stage renal patients have an extremely high suicide rate. That's kind of, to me, like well, duh. I mean, of course you're going to become depressed or anxious, and these things might happen. But those are things to think about in patients. The signs aren't always that obvious, though. That's the whole problem. So, psychic, unbearable psychological pain. People who die by suicide, I will tell you that my wife told me over and over again, I don't want to die. Please help me. I don't want to die. The pain is so bad, I'm afraid I'm going to hurt myself or kill myself. And she's a person she was on 6 different kinds of medications. She had a psychologist, a psychiatrist, a social worker. She did electroconvulsive therapy. She did self-help books, meditation, all these things, and that wasn't enough. So it's not a person that wasn't trying. So think of it that way. We reframe pain, right? So my 10 on a 10 scale is not the same as your 10 on a 10 scale. Imagine the worst pain you've ever had in your life physically. Mine is when I crashed an ATV into a tree, broke my proximal humerus, my left wrist, punctured a bursa in my knee, and did other kinds of lacerations. You could see my lips or my teeth through my third lip up here, and things like that. Just that was my worst pain. Prior to that, it was my gallbladder surgery. I guess I was a sissy in retrospect, but that was my 10. But now that's like a 2. So we all reframe pain. So fix that in your mind. Now think of the worst psychological pain you've ever had in your life. Mine was my wife dying. Hands down, worst psychological pain I've ever had in my life. And I will tell you, I'd rather crash my ATV into that tree 5 more times than go through one more episode of psychological pain that bad. I would gladly do it. And that's the power of psychological pain. But how often do we treat that? We don't really. I don't know a lot of people, except for maybe one example I'll give you here in a second, that died because of physical pain. But I know a lot of people that died because of psychological pain. So oftentimes think about that. It's more fatal. And yes, physical pain can lead to psychological pain for sure. So, first person to die at the 9/11 towers when they came down. Who was it? Who was the first responder to die? Anybody know? Anybody read the 911 Commission report? It's great reading at night, just when you're trying to fall asleep, gets you in a positive mood. It's like, he's got some problems. He's go back to his therapist again. Next week. So it was a fire chaplain. It was the first person to die during 9/11. What happened to him? Somebody jumped out of the tower and landed right on him. What a selfish person to do something like that. Why weren't they thinking of their brother, their friend, their mother, all the movie tickets they have next week, the trip they're going to take, all the money they have, et cetera, et cetera. And you can see the analogy. I often tell people, I'll do a little Gedanken experiment here. If I had, and I'm a sadistic type person, right? So say I have a ball peen hammer. That's rule number 1. And I'm going to be sadistic. But the rules are you'll feel every bit of pain I'm about to inflict on you. Number 2, not stop me. When I tell police officers this, I get all kinds of interesting, even more disturbing ways to stop me from hurting them. But anyway, you can't stop me from hurting you, and you're going to believe it will never stop. So I'll just take my ball peen hammer out. You're first, because you got a cool mask. So I'll just hit him over the head as hard as I can with my ball peen hammer. He's not going to die. That's the other thing. Can't die. And then I'll go to you. And then you, and then you, and then you, and then on and on and on. Everybody in this room gets it. Maybe I'll come back in 10 minutes. Well, you have a cool mask. I'm going to come back in an hour. I'm going to give you a little break. You got those half socks. You're going to get 10 minutes. You're going to get 10 minutes. Wham, right? Shattering pain. And as that hammer comes down over and over and over again on you, if somebody were to come up and say, that's selfish, why aren't you thinking of your spouse? Why aren't you thinking of your kids? That's the whole point. So I speculated if this were a real experiment, everybody in this room would take their life at some point, but just at different times. You could only take so much. All right, so that's the concept known as the psychic, developed by Dr. Edwin Schneidman, a psychologist. He is like the preeminent suicidologist. He's dead now, but he was like consumed with death. He's a thanatologist and a suicidologist. On his deathbed, he wrote a whole book where he asked his a select therapist to chronicle what is a good death and what was going to happen every step of the way. And a very interesting guy. He founded the American Association of Suicidology. Up until then, nobody really researched it much at all. So let's talk about, and we'll get some more theories later, but let's talk about the statistics a little bit, because I do have been known to teach epidemiology every now and then, so I managed to slip in odds ratio type stuff and attack rates and stuff later. But so suicides in the United States, 47,511. I'm using 2019 because the data isn't available for all these other things for 2020 yet, but I'll show you what happened in 2020. So just bear with me for a second here. So all those suicides, 47,511 suicides in the United States. We believe that's 20 to 30% higher because a lot of them are misclassified. Other causes don't get misclassified, either accidentally or intentionally. You've probably seen the patient, clear road, no bad weather, hits a single car, hits a bridge abutment, not wearing a seatbelt, no mechanical problem with the car, didn't have an MI, on and on and on. You can't rule anything else out. What is that? We call that an equivocal death. So we don't know. And that's what we use psychological autopsies sometimes for, to kind of reconstruct that perfect storm I'll talk about in a little bit. There's more, and there's a lot hiding. And I believe that there's a lot of overdoses that are hiding in these numbers. So what is that? What are those accidents with indeterminate prints? What was that? I mean, we don't know one way or the other. It could have been an accident. It could have been a suicide. Not uncommon amongst celebrities, unfortunately. Same year, 36,000 traffic deaths. I sat in the Toward Zero meeting like a couple of years ago. I don't know if anybody else has been in that, the traffic safety thing. They bring you those signs on the roads and stuff, and they say, like, there's been so many motorcycle deaths. And I'm the type of person who'll do the math really quick and go, well, there's been 200 more suicides. But we sat in this room down in Mankato, and we're talking to all these healthcare folks and public people about the high traffic rates and how do we get them down. I thought, this is ironic because the people in this room are dying in droves of suicide, and they're not, and they're still thinking of other people. And there's more of those deaths by a landslide than there are traffic deaths. And I'm not saying we shouldn't try to stop that. We should. I mean, that's how EMS got founded in the first place, right? I mean, that's why probably a lot of you are going to have the jobs that you have, because trauma centers were a part of that, emergency medicine. 16,000 murders, according to the FBI. People often think that people who are suicidal are violent or going to be the next active shooter. It doesn't stand up on its face if you just look at the statistics. It would be the opposite if people who are suicidal were going to kill somebody else. And you say, but what about active shooters and things like that? Not all active shooters are suicidal. It's a different psychopathology. So the person who goes in and shoots the place up and doesn't kill themselves is way different than somebody goes in and shoots the place up and does kill themselves. And unfortunately, we're putting them all in the same basket and trying to stop them that way. And I think that's a really wrong approach, because research is showing that murder-suicide is actually a suicidal event first and then a homicidal event. So suicide prevention can actually stop a lot of the murder-suicides. Incidentally, the vast majority of murder-suicides are spouses killing another spouse. That's 2% roughly of all the suicides here. About 0.5% are what we call mass murder suicides. Your odds of being killed in a mass murder suicide, just because I looked it up because I have an inquiring mind, 0.001%. Those are your odds. But just like shark deaths down here, sometimes there's one. There's none. There was none in 2019. Can you believe that? But there were 41 attacks. But if there's one shark attack that results in a death, it doesn't make you feel any better as the shark is munching on your leg. So I recommend still taking precautions and being aware of your surroundings and all the things that your mother taught you growing up, right? 3,700 fire deaths, according to the NFPA. I think all the money we put into fire drills and fire codes and all that, well, we've done a good job. And then 408 severe weather deaths. Lightning, hurricanes, tornadoes, floods, severe weather, extreme weather events, temperatures one way or the other, 408. That's it. And no shark attacks. I don't like the ocean because of sharks. It's just my thing. Because I think when you enter the ocean, you enter the food chain and not necessarily at the top. It's just my personal opinion. I'll talk to my therapist next week about that too. We're working on it. We're working on exposure therapy. Take me to the aquarium at the zoo. All right. So what about Minnesota? Good news. No shark deaths here either. But muskies? I don't know. I don't know. I live on a lake, so I always worry about every once in a while I see one when I'm on my paddleboard, like kind of shadowing me. I don't know why they do that. It's like, do I look tasty or what? But look at Minnesota. All these deaths combined don't equal the number of suicides we had. By the way, in this year, the number of breast cancer deaths amongst women this year, 42,000. Just to put this in perspective, what kind of a problem this is. So, only 3 people died in Minnesota weather, so that's good news. Now, these are averages, right? So, what happened? What's been going on in 2020? Well, for the first time in quite a while, the rates went significantly down. I'm not really surprised about that because research has shown that, like, during 9/11, suicide rates went down worldwide. During major sporting events, when your home team's team wins, suicide rates go down. That's because it's social connection. Everybody's pulling together. Everybody's either happy or trying to solve a problem together, and the suicide rates actually go down. I always say if you could pick one thing to prevent suicides, it would be social connection. I'm convinced that the majority of patients that I go to that are elderly on calls are lonely. The United Kingdom has taken this so seriously that they've established a minister of loneliness. I kid you not. It's that important to health. There's a doctor named Holt Lindstedt who did research and found that having an adequate relationship with one other person was more important for your health than quitting smoking or losing weight. That doesn't mean that you can go out and smoke and eat all you want, and so don't do that. But important to know. It's also one of the risk factors that we see, people starting to pull away from social circles, not coming around. They're not in a group with you. They're not bowling. They're not, golfing with you. They're not going just to dinner like they used to. And some people unplug from social media, and the really younger group, although I'm kind of guilty, I like to kill zombies. They're already dead, so it's not like against the law. But I kill them on video games, but gaming, because you can build social connections and talk to other people. I used to shoot zombies with the college president, and nobody ever believed me, but we did. We worked out a lot of things at night. Rumor has it I might play Dragons with a bunch of other highly educated people, but yeah, thank you. Human fighter, level 18. Yeah. All right. So, drug use, alcohol, deaths gone up. Are a lot of these masquerading as accidents that are really suicides? I don't really know, but I have suspicions that they could be. But is it also just because we're pulling together because of the pandemic? And that's why the suicide rates have gone down, and then they'll go back up later. So, yeah. So, interesting data. We talked about pain before. So who knew? Yeah.
Can I ask a quick question about the last slide?
Yeah.
Do you know anything about data with school-age kids
While they're in and out of school?
Yeah.
Education, this is because my doctorate is in education, and I did devote some amount of time to this. So education is a protective factor. Being in school protects you, it's social connection. It's interesting, but it's only to a point. And amongst college students, and I'm sorry, there was no research done on females, hard to believe. That's kind of like the curse of medicine, right? And the curse of health is that there's limited research on females or other minorities. But amongst white males, for every year of college you have up to a bachelor's degree, your chance of dying by suicide goes down 2%. Now, here's the other bad end. For black males, for every year of education you have up to a bachelor's degree, your chance of suicide goes up 8%. Why is that? You're leaving one group, you're entering another, you're not accepted here, and now you're not accepted here either. And so that's all about social connection. Yeah, exactly. So different types of pain. There's 3 flavors. Physical pain we know about, social pain, being bullied, not being included in all the reindeer games, so to speak. That can cause social pain and psychological pain. Interestingly, in the anterior cingulate cortex, that's where these things are sensed, in addition to other things, which is kind of interesting because dehydration is correlated to anxiety. Coincidence, maybe. So, what are people who engage in parasuicide, otherwise known as non-suicidal self-injury, doing? They're exploiting the cingulate cortex. They're overriding the psychological pain with physical pain, which only gives a temporary reprieve. And unfortunately, ultimately, it's more of a risk factor for suicide in the long term. And people always think of cutting, but adults engage in non-suicidal self-injury a lot, and it's oftentimes disguised. Punching walls, doing things like that. You probably all know somebody who punches walls. Go on a limb and say. It's typically a male behavior, but it's more acceptable, right? In the bottom here, I just put these in for fun. So lesions on the white matter in the limbic area. A couple things cause that: chronic alcoholism, prolonged depression, exposure to high altitude. U-2 pilots, not the band. But high altitude pilots experience that. I did a whole thesis on the Intermountain West and why suicide rates are higher in mountainous areas of the United States. That's our suicide belt, actually, in the United States. But I think it's something called a syndemic, which is 2 or more physiological things coupled with a cultural issue that make a problem. And that's called syndemic theory. Don't underestimate the power of culture. This is really interesting. Engdahl, down at the VA hospital here in Minneapolis, took an EEG and cross-referenced it with an fMRI and can see evidence of people who've had prolonged post-traumatic stress. So I think that's just really interesting, because people for years would tell me, well, I don't believe it. Mental illness is a thing. Show me the images, show me the whatever. And it's like, well, here you go. Or we'll look at a PET scan and somebody has depression and then they're treated later. And I mean, so there's things that can be done. So, but people just think it's all in your head. Well, it is, but that's not what they mean. And actually now we're coming to know that serotonin and some other things are produced in the gut too. And that the gut is a bigger deal than we thought it was for monoamine production. So that's something and if you haven't read Harriet Washington's book on that, she's not a medical professional, but she's really dug into it and did a really good job on it was fascinating stuff. There's another theory of suicide by Thomas Joyner. This says that 3 things have to line up for somebody to take their lives. One is a perceived sense of burdensomeness. That'd be like social pain, right? And then the thwarted sense of belongingness, and then the ability to enact lethal self-harm. What does that mean? Well, people like me who see death, people like you who see death, injury, I'm just going to say after a while, death has lost its charm. And you don't have to save me, but I'm going to say, I'm really kind of ambivalent about death. The notion doesn't really scare me. I don't care if my plane crashes. What I care about is the 10 seconds of sheer horror as it augers itself into the ground, right? And to be clear, I'm not suicidal, but thank you for asking. But we get ambivalent about it. That's why it's thought or speculated that veterinarians have such a high rate of suicide. Euthanization of animals and the pain and suffering of animals. Also, dentists have a very high rate of suicide too. You get desensitized to pain. And people who have a high pain tolerance, people with injuries. So there's lots of evidence to support that when these 3 things line up, bad things can happen. What do we look for? Here's some things to think about. Suicide is a perfect storm. I'm going to steal something from somebody named Iris Bolt, a prominent suicidologist. I'm just going to tell you what she says about the perfect storm. So imagine a glass, and you're going to put water in it. And what the water represents, the drops of water represent the risk factors, all this stuff. So you have ideation. By the way, the acronym is path warm. My guess is you're acronym people. Most people in medicine, that's how you remember just about everything, right? Is path warm. So you have suicidal ideation. And I could spend like whole day just talking about different kinds of ideation, passive versus active, et cetera, et cetera. Put a drop of water in the glass. You got a divorce. Put 2 drops of water in the glass. You have anger issues, explosive anger. Put a drop of water in the glass. You have depression, and on and on and on. Glass fills almost all the way to the top, but it's not overflowing, because when overflowing is the suicide. Your boss comes down and fires you. Last drop of water, it overflows all over the place, and everybody blames the last drop. Right? Suicide isn't that. It's so rarely one thing. You can't think about it as one thing. And the formula for the storm is different based on the person. Life is subjective. You and I take care of a trauma patient, and it's a 24-year-old woman. My daughter's 24. I identify with it. That's a more profound. That to me is more profound than maybe it is to you, who are maybe 24 yourself. So life is subjective. An identification hook is what gets us usually, right? So ideation, substance abuse, 29% of people die by suicide are positive for alcohol at the time of their death, but that I said positive, I didn't say they were intoxicated. But if you flip the statistics around, 71% are not. That's the hazard of statistics, right? You got to think about it both ways. Purposelessness, Viktor Frankl. If you have never had a chance to read Man's Search for Meaning, it's a good book. You should read that. He was a psychologist in prison in a Nazi concentration camp during World War II. And he started doing research. Why do people take their lives? Well, he found that when they lost their purpose, their meaning, that's when, soon after, they lost their lives to suicide. Anxiety, I have to tell you what that is. You went through medical school. So I'm just like, it goes without saying. Feeling trapped in a situation, a job, a relationship. Hopelessness. So I have a purpose, but I can't get there. People often confuse the two. It's a fine line there sometimes. Withdrawing from things, that's more of a symptom than anything. So withdrawing from social events or other things. Anger, disproportionate. Reckless behavior, not wearing a seatbelt when you used to. Not wearing a helmet when you used to on a motorcycle. Don't go out and try to save everybody who doesn't wear a helmet on a motorcycle. They'll get mad at you. It's the totality of the circumstances, and it's the change in behavior. Sexual intercourse with multiple partners unprotected is in the category of reckless behavior. Mood changes from high to low. Now there's other things in here, like sleep deprivation. Heavily, perhaps you've heard of this, sleep deprivation, perhaps you're in it right now. I won't even ask people to raise their hands because I pretty much know the answer. What happens when you want to torture a prisoner? When you get captured, you're a prisoner of war. What's the first thing they do to you? Sleep deprive you, right? Think of the most tired you've ever been, and imagine if you have to be that way for a very long time and no relief. Probably take your life at some point. And there's physiological reasons for that because important things happen when we sleep, right? So this data came from the CDC. They looked at 17 years of data of suicides, and these are the percentage of people who had these things going on. I put 2 in red because those are people you're probably more likely to key up on. Not that you couldn't key up on some of the other stuff for sure, because I wouldn't diminish the social aspect of somebody's life at all. In fact, amongst elderly people, the majority of elderly people who die by suicide in the United States seen their primary care physician within a month of their death. They're missing it. If you think there's any real predictive suicide screening tool, you'd be wrong. The most accurate, anybody ever see the movie Argo? Okay, so if you haven't seen it, it's worth a watch. In the movie, they go, is this the best idea you have? He goes, yes, it's the best bad idea I have. Right? So some of those suicide assessments are the best bad ideas we have. Don't use sad persons. That was meant to teach. It wasn't meant to do actual assessments. But unfortunately, I see that used in EDs a lot. Don't use it. Columbia Suicide Severity Scale is one of the more accurate of the bad ideas we have. But again, if you could get something that was really accurate, well, you'd be getting your Nobel Prize, probably. So that and the rapid assay for figuring out what monoamine you're short so that we can prescribe the right medication. But wait, we can tell who's receptive to what medication now. Better, yeah, but it might not be the drug that you need or the monoamine or neurotransmitter that you're deficient in. So these are just all part of that perfect storm, can be. Not everybody who dies by suicide has a mental illness. We've kind of medicalized it, or what I call Kreplinized it, because there was he's the physician that kind of first medicalized suicide. But there's different kinds of suicide, and I'll tell you, I mean, death with dignity, I don't think those folks are mentally ill. Whether you agree with it or not, we could sit here and talk about that forever, and you should hear the suicidology conferences when we get going on that. But I don't think those folks are mentally ill. There's different, we take a tour of the world culturally, self-immolation, Tibetan monks for political purposes to get a change in society. I don't think they're mentally ill. You could look at the practice of sati in India. That's not supposed to happen anymore, but where a widow is expected to throw herself on the funeral husband. That's a cultural expectation and a cultural thing. I don't think that person's mentally ill. And I could go on and on and on. Tribe in Papua New Guinea that punishes the men by the women suicide. So on and on and on. So there could be a cultural component. But these are the 4 biggies for mental illness. I do think, well, in that same CDC 17-year data, only 46% of people in that data set were diagnosed with a mental illness. Now, more than that had one, I'm sure, and were undiagnosed. The National Institute for Mental Health says 50% of the population has a mental health issue, but they have not been diagnosed. That's a little bit different than the 1 in 4 or 1 in 5, depending on the year that you see the posters or the billboards on the side of the road. But yeah, 50% of us. So I guess I'm one. So I know I'm not alone here. Borderline personality disorders are a really hard one because those folks are at really high risk for suicide, but they also get energized by making threats. So it's very hard for even the most savvy mental health professional to sort that one out. But I will tell you they're at high risk. Nicotine dependence, that was a surprise to me, and it is to most people I throw out there. But then I say, go look at the behavioral health unit and see what they're doing. And post-traumatic stress. If you wanted number 5 and 6, schizophrenia, chemical dependency. So physician suicide, what we're here to talk about today. So different results in different countries. New Zealand. So upper left-hand corner for those of you who don't know it, haven't memorized the shape of every country in the world. So New Zealand, it's not elevated. There is no difference between the general population and physicians. This is interesting because militaries are different in different countries too. Some don't have a higher rate than the general population. Ours, we have 20 to, depending on the year again, 22 a day of veterans in active military, majority of whom have not seen combat, which surprises people. It's a cultural problem as much as it is other things. In Australia, male physicians, higher rates than the public, but female physicians have a lower rate for some reason. I don't know why. I just know the numbers, right? And then the bottom left, the UK. So physicians overall have a higher rate than the public, but female physicians higher than male physicians. And then physicians that's Denmark. Kind of looks like a little troll with a hat on the top. That's how I remember it. Maybe that's like looking at clouds and interpreting what they look like. But physicians have greater suicide rates than the general population. So then you're thinking, well, who cares? Whatever. Well, here's the United States. There's several books been written on physician suicide. It's such a problem. There's been several books written on it. So this one's probably one of the better ones I've read. 300 to 400 suicide deaths that's like the shopping cart I have every time I go to Target. 300 to 400 suicide deaths per year conservatively, 1 physician suicide death per day, which is interesting because By the time I finish this presentation, there will be 5 suicides that have happened in the United States. But one of those a day, so you multiply 5 times 24, but one a day is a physician. So I don't think that's good. Female physicians 2 to 3 times more likely to die by suicide than females overall, and male and female physician death rates, they're about equal. So we don't have a disparity in sex.
Is this including medical students?
I don't know that it includes, I'd have to go back. That's a really good question. So does it include medical student data? I don't know. It would be interesting to see the medical student versus residency, et cetera, versus physicians, and then length of time of employment and discipline. But I can't find anything on that. Nobody's done that. That would be a great study. By the way, I have the death records to Minnesota going back to 1994, all natural accident, suicide, homicide, and indeterminate. So if somebody wants to team up and do, because you have no time or life, let me know. We can look into that. We can look into that question. So I had adapted this, but I think this about says it all. I would rather have the paramedic in the ambulance, the physician in the ED, the pilot in the cockpit that has depression, post-traumatic stress, or any other malady and is getting treatment than the one who's stuffing it, because those are the ones that scare the bejesus out of me. That's a medical word, bejesus. Yeah, they're just not dealing with their pain. They're not getting the treatment that they need. And a lot of times, like in my field, the majority of paramedics won't disclose because they did a survey because people will think of them as weak at work. They'll be passed over for a promotion, on and on and on. They won't even get promotional opportunities. I had a paramedic student who went to Alaska, tried to get a license up there, and Alaska said, denied, because she disclosed it. She was one of the first ambulances in on the 35W bridge. And they wouldn't give it to her, even though she was treated and doing well. Ultimately, they did. She did a letter writing campaign. And I wrote her a letter because she was my student, and multiple other people did. I remember I found mine on the computer the other day when I was just cleaning out my files. And I said, it's a shame that somebody like this, you're not going to allow to be a paramedic, because arguably this is a person who has empathy and should be in the ambulance. But she did prevail ultimately. So these are all the different kinds of treatments that you can get, abbreviations for all kinds of stuff. If people have questions and want to go into it, happy to do that. That is my contact information. I know we have 5 minutes or so left. I can devote some more time to questions, or I can throw out a few topics if you want. Yes, sir.
Is there a notion that this has changed over time?
This being suicide?
Physician suicide rate?
It's
Is it different than the 1950s?
Well, yeah, that's a good question. So has physician suicide rate changed over time, like, for example, from the 1950s? It's in the literature, they were talking about physician suicides being a problem in the 1980s. So I can tell you back that far. I don't think there was a lot of... Schneidman started out in the 60s, basically. Tail end of the 50s, early 60s. Nobody was really gathering data on suicide or cared that much about it. So I'm just going to say I doubt there's data, because the earliest I've seen is 1980s. And I'm happy to send some of those. I mean, I could send you an oodle of research papers on that, because I like to do literature searches, because, I don't watch the Vikings because I don't like baseball.
Just to piggyback on what you were just saying, what are the things, and maybe the answer to this is it's too situational, what are the things that you find are helpful interventions to our accept? And in that same question, when you look back and you do one of these autopsies, at facility in the last few years, what are the things that you look back and say, we think this may have been, what are the things, the interventions that actually seem to help change?
Well, the problem is we don't have I would call it a psychological biopsy rather than an autopsy, because we need to do something on somebody who's alive, right? And that's the problem with psychological autopsies. They don't hit what we call the Daubert standard in court for expert testimony, because they don't have a known error rate, because you can't go back and say, was I right? So unfortunately, that's a really good question, but it's a tough one to untangle. I always say social connection is a big thing. If you can talk to your peers is a big thing. Just garner support with friends, family, whomever, it's like a bad case, right? I mean, debriefing afterwards. Sometimes just the informal conversation with a colleague can be one of the most powerful things that takes place, and the willingness to listen. And there needs to be culture change that, like, it's okay to get help. No, really, it's okay to get help. And I looked at that sometimes with a jaundiced eye, because I used to say, I'm lucky I work for an agency where I can say this. And I did that for like years. And then I found out I wasn't. All it took is one administration change, and I wasn't lucky anymore. So, yeah.
Do you have any tips on, so let's say a colleague comes to you that's thinking about this, anything that's like a phrase or something you can say or do? Because I think a lot of times that happens after you think, oh shit, like,
Yep.
there's nothing else to say.
I think the human response is to not want to hear it and say things like, you're not thinking of, are you? Because you're saying, please tell me no, please tell me no, please tell me no. Or you wouldn't do anything stupid like, would you? That kind of a thing can really drive somebody away, because they might think that's, given their psychological pain, that's the smartest thing they can do today, right? So they may not internalize that. Judging a suicidal mind with a non-suicidal mind, it's not real possible. You can't, well, I'll just talk to them about their family or their money they make or something like that. It's not, remember that ball peen hammer coming down, right? That isn't going to help when I talk to you about that. But I think just having the conversation, and here's how a conversation should go. I'd say to somebody, usually you come to work, your hair is combed, you're well shaven, you're on time, and you're upbeat, and you're not anymore. And you just told me it's not worth it anymore. When people say things like that, I worry that they're thinking of killing themselves. Are you? And then stop. That's an old teacher trick. Because the one is fill the void, right? And that's how you should approach your patients too, by the way. That blunt. Don't say hurting yourself, because hurting can be different than killing yourself. That could be non-suicidal self-injury. And they'll get confused. Are you thinking of killing yourself? You'd be surprised how many people will say yes to that. If you do it in the right context with empathy, and then you need to get them to care, whether it's calling a National Suicide Prevention Lifeline, who's got resources. I don't know of any for physicians. There are lines for police, for firefighters, for EMS personnel. I don't know that physicians have a line. It's a good idea. If somebody has the energy to do that, would be a great idea. Or there's a lot of peer mentorships or peer support teams where they're designated people are on a team. And so there are people that are trained in suicide prevention and asking the question. There's a training called ASSIST, which is Applied Suicide Intervention Skills Training. Changed the whole way I do EMS. If everybody had that, the world would be a very different place, evidence-based. It's really good. It's literally how to talk that person off the bridge. Establishing rapport with that person. Tackling them isn't going to help. It will in the short term. It's not good in the long term. It's like counterintuitive stuff, right? And then you take a page from mental health first aid. Well, what makes you feel better when you've felt like this before? And then try to do that, right? And then means restriction is really important. There's an online course that's really good that I make all my paramedic students take. It's called Counseling on Access to Lethal Means. It's free through the Suicide Prevention Resource Center. It is excellent because means matter. Suicidal ideations are not a static proposition. When you have suicidal ideation, it's not a 6 on a 10 scale and it just stays there. It fluctuates from minute to minute, hour to hour. It could be a 10, it could be a 2, it could last for weeks, it could last for just transient minutes. That's why time is your friend in suicide prevention. So to your point about what can you do, first off, can you buy some time if somebody's in that kind of a state? Can you get them to help? Can you restrict the means? Locking up firearms. Everybody gets weird about firearms, but I like safekeeper programs like they do in Wyoming for all the cowboys that, you only get my gun when you pull it out of my dead hand, right? All these kinds of things that they say. But what you do is you get somebody they trust who's a friend, a buddy, to hold the gun until it's safe again. And those are received a lot better. England had a major problem, paracetamol or acetaminophen overdoses, that's what they call it there. And they really markedly dropped the suicide rates to paracetamol by outlawing volume bottles. They're only blister packs that you can buy in the UK. Why? Because it takes a lot of time to pop enough quantity out. It's just enough time in a lot of cases to make you reconsider or come out of that suicidal ideation level and have it drop a little bit to be receptive to help. So anything you can do to restrict that means. So if somebody says, yes, I'm probably telling people a lot of things they know. Yes, I am thinking of killing myself. Okay, when would you do that? Do you have a plan? Yes, I have a plan. What is that plan? And do you have access to the things that you need to carry out that plan? Those are very important questions. Well, it's a firearm. Well, who can take that firearm for you and keep it safe? Do you have a brother, a friend, a confidant? These kinds of things. So a lot of times the means of restriction is really, really, really important. So those would be things you could do. I'm afraid there's not like a lot of magic, but a lot of it's social connection. Really is. People always ask, what should I do, medications or therapy? And all I can answer is I'm not a medical, I always say I'm not a mental health professional. I don't even play one on TV. But I look at the research. So the research is pretty clear. In the short term, medications work better. Long term, it's actually cognitive therapy. I do both. It's not a one size fits all. So don't underestimate the power of a nice dog or a cat. I have cats. So, other questions? I know we're right up against the time, and I'm happy to stick around for a little bit. If anybody, call me if you want. I'm highly food and coffee motivated, so if you just want to sit down and have coffee sometimes, this is too important not to talk about and to do things about, because the people we care about are dying. People like my wife, people like my brother and my colleagues. We just need to do something together. And the biggest rub is you think I'm here for you. I'm selfish. I'm not. This is my therapy. This makes me feel like I have a purpose, like I have a meaning. So actually, you're more therapy for me than I'm probably helping you right now. So, but don't bill me.